All right, everybody, good afternoon and welcome to the Early Childhood Learning Community presented by the TA Network. My name is Lauren Rabinowitz and I'm here facilitating with my colleague Kate Wasserman. She will say hello in just a moment. We are really excited to welcome you today to the important topic of talking about sustainable financing for infant and early childhood mental health services and supports. We have a wonderful presentation for you with our colleagues at 0 to 3, and we will have plenty of time for questions and answers and discussion. Just a few bits of housekeeping before we get started. Hopefully everyone is connected and can hear us okay. If you have any questions or anything about technology not working, feel free to put that into the chat. You can also use the chat for any other sorts of questions or anything that comes up as you're listening to the talk. We do have everyone's lines muted right now, but we can open up the lines at the end for questions. But as we go through the presentation, if you have anything that is coming to mind, feel free to put it in the chat, and we will be sure to address any questions or concerns that you have as we go.
So welcome, everyone. My name is Kate Wasserman. I'm also with the TA Network, co-facilitating this webinar series with Lauren, and we're really excited to spend a little bit of time today talking about financing. I just wanted to spend a minute to orient you guys to kind of the intended flow of this from our last two webinars. Some of you may have had the opportunity to dial into those as well, or if you're just learning about this or your schedule is just allowing you to attend to this, those are both available on our learning platform, which Lauren will talk about more at the end of the hour and a half together. So you can access those recordings there, and as well as related resources. But for this goal that we have of being sort of a large collective that looks collaboratively and collectively at systems issues related to early childhood mental health, we intentionally started our January webinar series with a more global discussion around systems building and considerations for understanding the needs and systems drivers for infant and early childhood focused communities and projects. And then we spent last month focusing on how to understand and diagnose and assess the need of infants and young children and their families. And that really focused, again, on the 0 to 3 team sharing with us not only a little bit about how they built and designed their DC 0 to 5 diagnostic criteria, but also how some states have used that as drivers to make some systems change. And then today, we really, from the build of those two stepping stones, wanted to spend some time on the most important and pivoting question that everyone has in this work, which is around financing and sustainability and what those mechanisms are. So we're really pleased to have Joanna and Lindsay join us from 0 to 3 to talk about their national work on that platform, and also know that you can't address all of financing for an early childhood system within an hour and a half. And the old adage of if you've seen one state's Medicaid plan, you've only seen one state's Medicaid plan, very much holds true to early childhood systems, where the financing can be complicated in that it is happening in different siloed systems, and savings often come on after kids are out of the early childhood space. And so we hope that this is the beginning of a rich discussion, and really invite you guys to sort of share resources that you have related to this topic with each other on the learning management system as well. And we really look forward to really fully inviting you guys as participants to engage in the public chat, and we'll unmute lines and have a more global discussion around this as well. So with that, Lauren and I are happy and pleased to pass this over to our colleagues over at 0 to 3. I'm going to read you briefly about Joanna Lister's impressive bio, and then Lauren will read Lindsay's. Joanna Lister is the Senior Policy Specialist with the Policy and Finance team at the HealthySteps National Office of 0 to 3. In this role, she pursues sustainable funding for HealthySteps sites across the nation. She works with stakeholders, including providers, payers, and states, to promote favorable reimbursement policies and to help deliver critical services to children and their families within the pediatric and family medicine settings. Prior to joining 0 to 3, Joanna was a consultant with the advisory board company, and in that role she advised large health systems on strategies for growth, expansion, and market differentiation. Joanna's career has largely centered around the intersection of Medicaid and children's systems, including the role that Medicaid plays in child welfare, special education, school-based health services, and juvenile justice. She has a bachelor's degree with the philosophy in global public health and a master's of public health from George Washington University, and also holds a law degree from the University of Maryland, focusing in health law. And Lauren will share a little bit about her colleague, Lindsay.
Thank you so much, Kate. So Lindsay Arcia is a senior policy analyst for infant and early childhood mental health at 0 to 3. In this role, Lindsay helps to develop and implement 0 to 3's federal policy agenda, as well as state technical assistance projects. Most recently, Lindsay was the lead on a communications research project intended to identify messages that help specific audiences understand infant and early childhood mental health and learn which messages are most effective for communicating key points about how emotional development can be promoted and supported in infants and young children. Lindsay also led planning for a successful 10-state infant and early childhood mental health policy convening and follow-up technical assistance project. Lindsay was formerly Director of Special Projects for the Institute of Infant and Early Childhood Mental Health at Tulane University School of Medicine. She also served as the Early Childhood Comprehensive Systems Coordinator for Louisiana, working with their Office of Public Health. She received a BS in Neuroscience from the College of William and Mary and an MPH in Global Maternal Child Health from Tulane. She has previously worked on international child development issues with the U.S. Government Secretariat for Children in Adversity at USAID, as well as the World Bank, and spent 3 years as an elementary special education teacher. So as you can hear, you are all in very good hands to learn about this important topic, and so now we will turn it over to our colleagues, Joanna and Lindsay. Thank you so much.
Hi there. Okay, this is Lindsay. I'm going to get us started, and then I will hand things over to Joe. So first, just to tell you a little bit about 0 to 3, you probably saw maybe even this same slide if you tuned in for the presentation about developmentally appropriate assessment and diagnosis. But 0 to 3 is a nonprofit, and our mission is to ensure that all babies have a strong start in life. And we pursue this mission by working across a broad array of issues and audiences. We work with parents, all different types of child and family serving providers, and also with policymakers. And so you'll just hear about a subset of our work today, but you can learn more at our website. So today we're going to talk about, first we're going to sort of root our conversation in the continuum of infant and early childhood mental health supports and services, and explain a little bit about how we kind of conceptualize and organize our work and our thinking about infant mental health supports and services. And then Johanna's going to talk to you a little bit about the HealthySteps model, kind of introduce it for those of you who aren't familiar, and then to talk about the work that she and her team do to really examine financing options for specifically thinking about the promotion and prevention of the continuum. Then I'm going to talk to you a little bit about our infant and early childhood mental health financing policy project, and then talk more about financing approaches at the deeper end of the continuum. So this continuum that I'm talking about, this is just a visual to orient you to the continuum if you're not familiar with it. This is very much a public health kind of conceptual map. And really we think about the supports and services that we want to ensure are available to young children and their families across this continuum, from promotion to prevention, to treatment. And this diagram used to only have 3 blocks, and then we realized that we spend a lot of time and invest a lot of our energy in working on the DC 0 to 5, and more generally on policy and training to ensure that young kids have access to developmentally appropriate assessment and diagnosis, and that really we should make that an explicit part of this continuum, so because it is an important kind of transition point there. So when we're thinking about the continuum, we're thinking about promotion. What are the supports and services that should be available to everyone to ensure that every baby has access to those nurturing relationships and safe and stable environments? And then stepping into prevention of what supports and services might be appropriate for indicated populations where maybe there's a little bit of an element of risk, or where a family is indicating that they want additional support. What are those prevention elements? Then, like I said, developmentally appropriate assessment and diagnosis, and then up into developmentally appropriate treatment, mental health treatment. So now that we've got that kind of foundation, I'm going to kick things over to Jo.
Great. Thank you so much.
Before
I get started talking about Healthy Steps a little bit, would love to just understand how familiar people are with the model. So if people could just type in, just say sort of yes, no, a little bit, help ground us and help me understand how much to dig in here.
We are getting a little bit of an echo, so we just want to make sure that your computer speakers are muted.
So let me try one thing. Okay, is that better?
Yes, that's a little better. Thank you.
Okay, sorry about that. I think this is the best we can do right now. Okay, great. Well, I am going to dig in a little bit to Healthy Steps, and again, apologize for the feedback. So, Lindsay talked about the continuum, and Healthy Steps is really a promotion and prevention program at its heart. So that's why we wanted to begin this conversation talking about Healthy Steps and some financing opportunities, and then sort of move into what we think of as more classic interventions. But Healthy Steps is really an interdisciplinary evidence-based program that takes place in pediatric and family practice settings, really wherever a well child visit takes place. And the focus of the program is on children birth to 3 and their families, or some of our programs go birth to 5. And the model really centers around expanding the care team and embedding a child development specialist known as a Healthy Steps specialist into the primary care setting. They can really work closely with both the pediatric care team or family medicine care team to promote nurturing parenting, healthy development, but also work with the family and the child individually as well. So I'd like to talk a little bit more about why the pediatric setting. And of course, this is an early childhood crowd, so I think we know the struggles that a lot of us face when we're trying to deliver services to really young children. They're not in school, they're not in any kind of quote-unquote system traditionally. So we really try to leverage the primary care setting as a place to get to serve those children. Most parents do take their children to well child visits, and it's really a positively stigmatized environment as opposed to how some parents may feel about mental health clinics or behavioral health services. So we really try to capitalize on the fact that parents are really trusting their pediatricians and are going to see their pediatricians. I just want to talk briefly on the tiers of service delivery, and I'm happy to answer any questions about the model, but don't want to spend all of our time on that, so really just wanted to give us some grounding. But when Lindsay talked about that public health continuum, I think it's a good parallel to the way that we see Healthy Steps as really a tiers of service delivery. So we have listed here the 8 core components of our program, but it really varies depending on the need of children and families, just like Lindsay said in terms of that promotion, prevention, intervention. So when we think about the promotion side of things, those universal services, screening everyone, making sure that all parents have access to a support line where they can really understand, have questions about development and things about their children, and also really connecting people with social determinants of health support. And then we sort of move along the continuum and talk more about short-term support, where the HealthySteps specialist can really engage with a family or caregivers about any concern that they may have with the child, or maybe it's around sleeping or feeding or behavioral issues. And this, really is infant and early childhood mental health, focusing on that dyad and strengthening that dyad. And in this quote-unquote tier, we also do a lot of systems navigation, so referring children to services if they need more than what we can provide at HealthySteps, referring moms for maternal depression, really helping with that systems navigation piece. And then in Tier 3, which we consider our most comprehensive services, that's really where the HealthySteps specialist is involved in every single well-child visit. So they can really be with that family and child from ideally birth to 3 and work with that family to help them get all the supports that they need and really set them up for success. So since we are talking about financing today, I wanted to just touch on what we do at the HealthySteps National Office in terms of sustainability support. So we have a dedicated policy and finance team, and we engage with sites in a variety of support and technical assistance. And first and foremost, this really includes supporting sites with billing for HealthySteps services. And as Kate mentioned, every state has different billing requirements, but what we try to do is provide some resources to help sites think through where to start and where to sort of capture that quote-unquote low-hanging fruit that can be out there that will not fully support any kind of child-serving program, but can certainly help. And that's what we're going to be digging into a little bit more today. But we also work with our sites to help understand the shifting policy environment and how that may impact HealthySteps in terms of the provider side, but also the families and children that we serve. We're working on some other ways to articulate the value of HealthySteps, and we call this the business case, where we've done some single state analyses where we're able to determine an actual annualized ROI for Medicaid. And this really helps us talk to payers and help those who think very much in dollars about the value of HealthySteps. And when I say HealthySteps, I'm talking about that specifically, but of course, mean for any model that really serves young children. And then of course, we engage with our sites around helping them have these conversations as well. So today we want to dig into that first bullet around the National Office Sustainability Supports, which is about helping our network understand billing opportunities. And we typically do this through an exercise that we call financial mapping. And again, this is specific to Medicaid, I should note, because most of our kiddos are in Medicaid as well as their parents. We ultimately want to find diverse funding streams to support our work. I think we all are in agreement there. But this Medicaid financial mapping is really a good starting point for understanding the landscape and getting a foundational picture of your state and then really being able to guide your sustainability work. And I also want to note that many of our sites are initially funded through grants, and sometimes people are hesitant to bill when they're grant funded, and there are times when people can't. But generally speaking, billing while grant funded is okay, and it's really the optimal time to start exploring other payment mechanisms, because when you're grant funded and when you don't have to worry about money is a great time to start to bring in that diverse funding stream. While Lindsay will talk a little bit about some specific state examples, as she said, kind of further down the continuum, what we also wanted to do today was to give you some actionable steps in terms of understanding your own payment landscape. So that's what we're going to try to do here and talk through this process of financial mapping. And as Kate and Lauren said, these slides will be available, so no need to write all of this down at this point. But as we start exploring the mapping process, I want to highlight some of the overarching billing considerations. And Unfortunately, we do not live in a healthcare system where Medicaid reimbursement is as simple as yes, the state will pay for the service, or no. So when capturing the billing and reimbursement information, it's really important to include these details when available. So the first I want to touch on is site of practice. And there can be broad differences in payment structure depending on the type of practice. So for example, FQHCs have a unique payment system that's completely different than private practices. And in some states, practices can opt in or out of specific payment arrangements. So this is really important background to know before you start doing that research. And site of practice is actually a little bit different than service setting, which is listed here in the second consideration. And this is really around the location of where services are provided. And some payers, for example, will pay for a social emotional screening, but only in an office setting. So these are particularly important considerations in infant and early childhood mental health, as services can be provided in the community setting or in early care and education settings. And then finally, we have type of provider, which is a little bit more self-explanatory, and some services will only be reimbursed by Medicaid if delivered by a specific provider. Moving on, I've looked at a few other billing considerations because these are important if you do want to dive in and do this financial mapping. But these are a little bit more nitty-gritty. So the first is modifiers, and these are usually letters that are added to billing codes to signify something. So it could designate a provider type or a service setting, but these can impact the reimbursement rate, so they're important to note. And the next is unit. So for example, in HealthySteps, we do a lot of screening and referral. And typically, if there's an open billing code, the unit is one screening. But for our other services that we provide, like parental education and counseling, the billing code may depend on the amount of time spent engaging in that activity. So there it may be 15-minute increment is the unit. And then eligibility criteria, and this can be very tricky and frustrating when working with young children. We may find that a service is only reimbursable if the child has a certain diagnosis, which is a great opportunity to advocate for using the DC 0 to 5. Or in states that have a carve-out, there may be pre-authorization requirements to provide a certain service and get reimbursement for it. So all of these are important to note as you go about that financial mapping exercise. And again, I'm happy to answer any questions or talk through any of this further. I know it's a lot of information, but I want to now talk about the process and how you do this. Given all the information I just gave, it can seem a little bit overwhelming, but really this is a research project. And what I always say is start with some general background research, and especially in a group like this with so many people that are working and committed to early childhood, it's great to tap into those resources and see if anybody has done this work. Often you'll find that your local AAP chapter or Association for Infant Mental Health may have good resources. And I've never had a slam dunk doing this, looking for these resources already made, but they can be great in terms of finding a good starting place or finding contacts to reach out to verify the information. So moving to number 2, regardless of your delivery system, and of course these can vary hugely. It can be managed care, it can be fee-for-service, you can have a behavioral health carve-out. There are a variety of ways to provide services to children and families. But regardless of what that is, it's still helpful to map out the discrete codes. There's often more flexibility through managed care contracts, but understanding that payer landscape will really help you down the line in this process when you're ready to talk to payers. So having that information in the backdrop will really inform those conversations. So moving on to where you do the research. Generally, the bulk of the information that you're going to be looking for is in the provider manuals. And again, just to reiterate, this is all for Medicaid. And these can really be your best friend or your worst enemy, depending on the specific services that you're researching, and of course, depending on your state and how available that information is. And I may not have mentioned this explicitly before, but it's within these provider manuals that can make this work so tricky with the vast variation between states. But I will say that the variation between the states can be really positive when you engage in advocacy work down the line,
because you can point to states that have, say, open codes or higher reimbursement rates and show how they're performing well. And that can be a really powerful tool to try to affect meaningful change in your own state. But in terms of the provider manual, there are a lot of them. This is not an easy research project in the sense that you find one place and all of the information is within. So this is an example from Maryland, and this is a screenshot of only some of the provider manuals that they have. But it's really important to just look at that as a starting point and start to dig into those that you think may be helpful. And once you get into those provider manuals, control find can be your best friend, and it can be a little less overwhelming than it seems at first. It is really important to note that if you're working on the caregiver or maternal side, that you may be looking at a different provider manual. So in HealthySteps, because a lot of our sort of interventions or services do focus on that caregiver side, we would need to look at all of the children's services and then at the sort of general or adult provider manuals as well. So this is, I should note also before I go in further that this is the way that we've done it. This is our process and it's worked pretty well, but that's not to say that it's the only way to do it. So definitely want to note that there is no one right way to get at this information. But once you go through those provider manuals, this is really where we begin to record the information and get a much better sense of how comprehensive the provider manuals are and how much additional research and outreach you'll need to do. So you should have been able to identify the relevant codes at this point, but there may not be much information beyond whether that code is open. So then you can search outside of the provider manuals with a much more refined search. And if you're not sure whether information is relevant or accurate, I would encourage you to record it separately, and then you can revisit it when you've done more research or when you're able to speak to somebody who can provide answers. And also, depending on how you intend to use this financial map, you may find some of these specific points, like modifiers and units, aren't helpful, which is great because then you can create a higher level financial map and not worry about some of those nitty-gritty overarching considerations that we touched on in the beginning. I will say that for states that utilize the DC 0 to 5, it's really important to note that information in here when you can. And if your state isn't recognizing DC 0 to 5, this is, of course, a great advocacy opportunity. Great. So at some point, you exhaust your internet research, or you keep revisiting the same page over and over, and you need to move on. It may be hard to know exactly when to do that, but I would encourage you to reach out to Medicaid on the earlier side or confirm your findings. And there are a few benefits to doing it early. A, it may take a while to find the right person to talk to, and that's okay. Also, it may be that you're going down the wrong path, and I will say that I personally did this and created a whole billing guide and then spoke with Medicaid, and they said that that actually wasn't relevant for any of the practices that I was describing because they used a different billing methodology. So had I engaged with them earlier, they would have been able to direct me to the appropriate billing methodology. So absolutely encourage you all to do this. And the other piece is that you may get inconsistent information in the provider manuals, which can be very frustrating, but talking to people can often really clarify that. So I want to just touch on sort of the why behind your financial map. I talked about the fact that you're doing some overarching landscape research and understanding the payment structure in your state, but you can also then really use this as a tool. So some ways that we've used this is to send it out to providers to tell them, listen, you can bill for these services, whether it's screening or whether it's parental counseling and education or smoking cessation, whatever it is, those little pieces of revenue that you can bring in can help to support your program. We also, because we're not experts in the billing and coding per se, include resources and where to go with questions at the state level. You can also advocate with payers, and you can do this broadly in terms of talking about the need for the DC 0 to 5, or you can do this in a really specific way. So you can point to 96110 and the fact that that code gets $4 for reimbursement, and you can advocate that this is so critical to screening children for a variety of things, this needs to be a higher number. So there are a lot of different ways to use this information to really communicate with payers. And then you can also educate legislatures, so the broader advocacy beyond just the payers. Inform them of potential cost savings to really use it to show them what their state is supporting and not supporting. You know, I think a lot of state legislatures will talk a big game in terms of early childhood, and sometimes it can be really helpful to gently remind them of ways in which they actually support those services. So before I toss it back over to Lindsay, just want to touch on key takeaways quickly. And just as you pursue billing opportunities, you know, engage leadership within your system or your practice, review all the available resources, which we've listed here, and then absolutely verify the information with Medicaid or EI or whomever the authority is that you're working with. So I will turn it back over to you, Lindsay.
Joanna, this is Kate. If I could just capitalize quickly on a question, because I think this aligns a little bit with our discussion last month around around messaging. And so if I could just take us back to the slide that you had passed, just about using the financial map to advocate with payers and with legislators and leaders. Have you found a consistency, or does it sort of vary by region and target around, you know, messaging as it relates to infant and early childhood mental health and parent screening and all of those types of things?
So I think where this can be really helpful, and it's a great question, and yes, it varies. Mm-hmm. What I found this to be helpful is talking to sort of higher level legislatures, people who aren't in the weeds, and showing them how little the reimbursement rate can be for really critical services, or showing them all of the hoops that need to be jumped through to provide a certain service to a child. So they may not be in a position to directly, you know, raise that rate through Medicaid or, you know, waive a pre-authorization requirement, but it can be helpful in terms of the broader advocacy effort just to let them know, you know, what it really looks like for those who are providing the services and the challenges that they're having to be able to bring in enough reimbursement to support these critical services. So I'm not sure if that totally answered your question, but you know, it also just varies on the receptivity of whoever you're speaking with, of course. Yeah. But I will say that states, you know, get competitive with one another, and if you can point out that a state may not be doing particularly well in their developmental screening rate, and you know, lo and behold, their screening reimbursement is $3, you know, that can be really impactful for a state to hear and understand. In terms of incentivizing providers to do more screenings, well, maybe we need to have a higher reimbursement, and then we're performing better on this pretty crucial metric across the country.
Yeah, and you guys just published the state of babies, right?
Yes.
So can you share a little bit about what people would find in there?
Yeah, actually, Lindsay, I'm going to turn that over to you because you were a little bit more involved with that.
Great.
Yes, certainly. So I was just trying to see if I could grab a copy that I think is at my fingertips. I will give the disclaimer that I am not on the team who authored State of Babies, but I can certainly talk a little bit about it. This is a venture that we sort of took on with Child Trends in the past year. And if you're familiar with 0 to 3, you might be familiar with our state baby facts that we have published annually over the past many years, or maybe it's every 2 years or annually. That's sort of a snapshot of how babies are doing in states. And so the State of Babies yearbook is an effort to sort of deepen that work, to produce a snapshot that really looks at a number of indicators of infant and toddler well-being as well as policy metrics. So looking at what policies states have in place that we know support the well-being of young children and their families. And the information is organized across our policy framework, which is organized into good health, strong families, and positive early learning experiences. So it examines a number of policies in those policies and metrics in those categories. And then there is a state ranking system where states are ranked within those categories, and then there are also some overall rankings. And it's the ranking system that they've developed is called the GROW system, and so it's states who are getting started, reaching forward, improving outcomes, and working effectively. And so it's interesting to see that in a state, there might be a state that we think of as a pretty high achiever or as being pretty ahead of the curve in a lot of their child outcomes. But when the data is broken down across these different areas, the results shake out in pretty interesting ways. So to see, a state might be overall ranked in one of the higher tiers and may have, for positive early learning experiences, a really strong score, but they might actually be in the lowest tier for strong families or something like that. So it's an interesting way, and what I think we hope it will be is a tool that can help states take a look more closely at not just the broad strokes of like how are we doing for kids, but really looking more specifically at what are the areas where we maybe have invested and those investments have paid off, and then what are the areas where we might want to turn our attention or invest more deeply or newly. So we have the yearbook itself, and then we also have a companion piece called Promising Approaches at Work in States that sort of highlights just examples of great stuff happening in different places. And so there's information about paid family and medical leave and Medicaid access and things like that. And then there are also additional companion pieces, one for each state. So there are state profiles that show the rankings for the state, the demographics. So I'm actually holding Connecticut's snapshot in my hand, and there's an overview that talks about how many infants and toddlers there are, what % of the population are they, what are the breakdowns for race and ethnicity, working moms, poverty status, grandparent-headed households, rural, non-metro, as well as information about family structure. And then lots of information, just a really nice quick snapshot of the 6 indicators of good health, 6 indicators of strong families, and 6 key indicators of positive early learning experiences. So there's just a ton of information in these, and we're really grateful to Child Trends for their partnership in the analysis. So I encourage you guys to go check it out on our website. If you just Google State of Baby's Yearbook, it should take you to everything you need. And there's also, I believe, on our YouTube channel, there is a video. We held a policy forum at the U.S. Senate and released the information, had speakers from a few states there, and had state advocates from a number of states in attendance. And so the videos from that are there if you want to see a little bit more of a comprehensive presentation of the methodology.
That's wonderful. It sounds like a really great place for people to start if they're looking at educating folks that make decisions around where their state is in comparison to others.
Yes, absolutely. And I really love the state snapshots. I think the team that worked on it did a really thoughtful job of thinking of this as something that you can take in your hand and hand to a policymaker. It's not excessively wordy. It's not, the yearbook itself is quite thick, but these state snapshots are, 4 pages in total, and they're just really clean kind of delivery of the data. So I definitely recommend people kind of, taking a look and then thinking about taking those into your conversations with policymakers. Or if you are a policymaker, make it some commute reading.
Great. Thank you for taking that left-hand turn with me.
Yes, no problem. No problem. I'm glad I was equipped.
I just think it really aligns with this whole idea of messaging is I think, a big commonality in all of these discussions.
Yeah, absolutely, absolutely. And I do think, I mean, that's a whole, if we discovered that people had interest in that material, like we could do a whole other talk on that, I think. So definitely encourage people, if you're interested in learning more, feel free to indicate that to us. And we really want to make sure, this was just released at the very end of February, and the rollout is still in progress. And we really, really want to get feedback from states about how we can support people in making this as useful a tool as possible. It's a big investment of our time and energy, and we want to make sure that it pays off for states. So we welcome feedback. So now I can pivot and talk about our infant and early childhood mental health policy project. Within our policy center, we have a focus on infant and early childhood mental health. It's a lot of sort of the foundations of our organization are really rooted in infant mental health. And so we spend a lot of time working on this area, and we've tried to, over the years, we try to adjust our strategy as we go to be really responsive to the needs of the field. And so that has, shifted as the status of the field and the status of infant mental health policy really has shifted nationally. And so a few years ago, we were really getting feedback that there were just a lot of unanswered questions around how to actually pay for infant mental health services across the continuum, and that would be an area worth investing some time. And so we worked with some of our colleagues, particularly colleagues in Minnesota were really instrumental in this, because they had secured a significant investment from their legislature and had done some pretty massive overhauls of their behavioral health system, and really made infants and toddlers and infant mental health service provision really woven into their behavioral health system, and really started to shift to conceptualize their behavioral health system as a prenatal through the lifespan kind of system, which is pretty unique. As anyone who is working on infant mental health policy knows, a lot of the time what we are faced with is to take a system that was not designed with any recognition of the fact that young kids can have mental health needs, and then trying to educate, increase awareness, and investment in the concept that they can and that we should be addressing them. And then once we've gotten that investment and that buy-in from our colleagues, then trying to, in various ways, sort of stretch and wrangle that system down, pull it down to make it reach the youngest members of our population, and then try to find ways to educate and adapt to also make sure that the practices that are happening there are developmentally appropriate and meet the needs of young kids and their families. So Minnesota are really some pretty progressive folks in this arena, and so they helped us sort of develop this project. And we started in 2016. We put out an RFA, and we received a lot of applications. We were able to select 10 states, but we knew that the interest was really significant. So we spent about a year and a half in the first cycle of the project, and then we recruited a second cohort. We put out a new RFA, selected another 10 states. We brought those states together in May of last year, and we are now in our technical assistance period with this second cohort. So at this point, we have a group of 20 states. We are still having some nice participation from our Cohort 1 state team leads. They are still a part of we have an online learning collaborative, and they still participate and join us for calls and webinars and things like that. And we're in a more intensive technical assistance period with our second 10 states, our Cohort 2 states, where we are, having monthly check-ins with their teams and doing site visits and various things like that. So the goal of this project is broadly to advance state financing policy related to infant mental health assessment, diagnosis, and treatment. And we're trying to do that by, facilitating a lot of state-to-state learning and trying to be as responsive as we can to the needs that the folks who are doing this work in real time are identifying as they're going. For the two convenings that we've had, we had our states form multidisciplinary or cross-sector teams, and we required that their travel, they could have as big of a team as they wanted at home to do the work, and a lot of times they've tied it into existing early childhood mental health groups, so young child wellness collaboratives, different groups like that. But for their team that actually came to the in-person meeting, we required them to have their Medicaid director or a high-ranking designee thereof, and we required them to have a currently practicing infant mental health clinician, and then they could decide who the rest of their traveling team would be. And our idea there was, Joe spoke to this, about having the power in facilitating these conversations where people who are actually doing the clinical work are able to have conversations with people who are making decisions about how we pay for the clinical work to really illuminate issues that we otherwise might miss. So we have put a big emphasis on those conversations being a part of this project. There's a lot that we could talk about. This project has been obviously going on for a few years, and it has been, based on sort of the interest and the momentum in the different states. It's taken us in a lot of different directions, and there's been a lot of breadth of the topics that we've touched on. So today I'm really just going to talk about some kind of high-level themes from the project, and then I'm also going to encourage you to, you'll see throughout here I'm pulling excerpts from a paper that we just put out called Exploring State Strategies for Financing Infant and Early Childhood Mental Health Assessment, Diagnosis, and Treatment. We love a nice long title at 0 to 3, but that's a paper that we just put out that summarizes a lot more of the kind of key findings and the successes that states have had in the project. So I'm just going to touch on some key highlights here. One of the things that's been most interesting about this work is that while we set a pretty narrow focus on financing policy, the reality is that there are a number of kind of types of policy objectives that people who are pursuing a robust infant mental health system are having to hold in mind at once, and are really having to pursue hand in hand. And so the question of how do we pay for the services is definitely one of them, and it's the one that we kind of went into this aiming to focus on. But we found that it is really inextricably linked with the question of how do we grow, train, and support the workforce, and how do we ensure an adequate workforce? Because we find ourselves, I think, in a cycle of if we invest too much energy in raising awareness of the need for services, screening folks and getting them referred to services and figuring out how to pay for those services, if we have not invested simultaneously in making sure that we are growing and training our workforce, we find that there is no one at the end of that referral pathway. And so these really are objectives that I think have to be pursued hand in hand. And so the project has grown, I think, to try to support folks in states in thinking about that kind of duality. So in terms of the work that our 20 states have been doing, we've seen, first of all, that there's a lot that has to be done around just educating stakeholders in Medicaid, in behavioral health systems, in other child and family serving kind of spheres, educating about core concepts of infant and early childhood mental health, what best practices look like, and helping understand what those barriers are. And that's where having clinicians be an active part of this has been really helpful. And then there's always, in any systems work, there's that relationship building. And, Joe talked about finding out, like, has anyone else done this work? What's the, what investments have we already done? Let's not reinvent the wheel. And so a lot of that kind of exploration up front. Also seeing a lot of emphasis on cultivating leadership. So a lot of states have state associations of infant mental health and are trying to build that infrastructure, build the capacity and the sustainability of those entities, as well as pursuing positions in state government that focus on infant mental health, or constellations of positions that work together to really explicitly address these issues. And then a lot of mapping. So we brought Joe in to talk with our folks. We've brought people from other states who've done innovative mapping. The people we're working with in states are doing mapping on a number of fronts. They're really trying to answer big questions of who is our workforce and where are they not? What is our service array? What do we have to offer, and where are there gaps that we might not be seeing from our vantage point? And then also, what are those funding streams? And so then trying to think about how to pull information together from those three types of mapping. Also, of course, we spend a lot of time on the DC 0 to 5, and so really supporting states and trying to think about making sure that developmentally appropriate assessment and diagnosis is just part of how business gets done, and that if we are diagnosing young, well, first of all, that we are having a conversation about diagnosing young kids and what the utility might be in that, and addressing any discomfort with that. And then also making sure if we are diagnosing young kids that we're using a diagnostic classification that makes sense for them, that's developmentally appropriate and evidence-based. Then, like I said, the workforce element, and that infrastructure piece, and then really getting into the details of what Hannah has talked about in terms of navigating Medicaid levers and those opportunities both with Medicaid, with managed care organizations, with private insurers, to really assess, where are there opportunities and potential to generate momentum in our state financing policy discussions, and then what are the levers that we might be able to target. So we've seen work around definitions of medical necessity and processes for determining medical necessity, for looking at how infant mental health might show up in managed care organization contracts, in Medicaid state plans. And then we've also seen exciting things with states getting infant and early childhood mental health folks to the table for Medicaid waiver discussions. Alaska had some success integrating infant mental health into one of their waivers, and we've seen a few other states at the table and an active contributors to the Medicaid waiver or Medicaid redesign processes. In the paper that I mentioned, that Exploring State Strategies paper that a lot of this is drawn from, we share these 10 tips, and our team kind of laughed when we were pulling them together because we held our convening in May, and we listened to what folks from these 20 states were talking about, what our 10 cohort 1 states were sharing as their sort of learnings and achievements from their year and a half in the project, and then what our 10 cohort 2 states were talking about of sort of their ambitions of what they were hoping to tackle in the the coming year of TA. And there were all of these themes that came up that feel sort of maybe they feel obvious or they feel really like intro level, but in reality it does seem as though when people are having success, it is these kind of basic elements that are really helping them do that. And I think that's because a lot of this, in terms of the work that has to be done to advance infant mental health policy, particularly in the financing realm, a lot of this is still relationship-based work because we are just navigating systems that have not been designed with infants and toddlers in mind, and who are run or have decision makers in place who have just never been asked to think about the experience of infants and toddlers and the experience of their parents in this system, and who, like I said earlier, might not have any familiarity because they've had no reason to with what mental health problems can look like in young kids, or that those are even a possibility. So there is a lot of relationship building and education and kind of consensus building that's involved. And so a lot of the tips that emerged from our cohort 1 states were things like be aware of unconscious assumptions. You know, I think a theme that we've seen that's emerged is that people will assume that if something isn't currently allowed in a system, or if a rate is really low or something's not reimbursable, it's because someone had the information at their fingertips and made an executive decision that that should not be permitted or should be paid at a low rate. And a lot of times that's just not the case. You know, the folks who are currently in a decision-making position may have never been a part of this discussion, may have never been approached by anyone to say, this isn't working and here's why, or why don't you consider this change and let me give you some information about it. So being aware of some of those unconscious assumptions that we might come into policy discussions with in terms of assuming what information our colleagues have had in the decision-making process. And then I think another one that stands out to me that I think Joe kind of touched on as well, of not getting discouraged by what you don't know. I think particularly with people who are more at the service provision level, we heard a lot about having to overcome a sense of just being really overwhelmed by how big these systems are, by how many decision makers there are, by how many levels of decision making there is within state systems and you know, in the billing process and things like that. And so just really being persistent in pursuing answers to questions and being open-minded about that. So those are just some of the tips, and I think the paper spells out a little bit more some of the experiences that folks had with these. So now we wanted to share just a handful of examples along the continuum to give you a sense of what we are talking about. And there are definitely more examples in the paper, and I think we're looking to in the future hopefully share some policy vignettes that capture things like that, because we have gotten the impression that these sort of real examples are helpful to folks. So we wanted to give examples of just a few different things along promotion, prevention, diagnosis, and treatment. So in the promotion and prevention range, we have a few examples for you. So one of just people investing in HealthySteps. I think this is a really great way that we can infuse infant mental health expertise and access to infant mental health services into pediatric care, and so investments there in that promotion and prevention are really promising. Alaska has done some really interesting work. They were part of our cohort 1, has done some really interesting work around ACEs and some pretty creative analysis looking at the cost of not addressing adverse childhood experiences. And they did some analysis around that and brought it to their legislators and used it to drive a really productive discussion with legislators about why they should be investing more. And now there is there's a good conversation happening there, some promising conversation happening. And then also here we would put in, you know, work around billing for maternal depression screening. This is one where there's just a ton of national momentum and interest around this right now, and so it's promising to see states allowing for billing of maternal depression screening, both in the you know, primary care setting and in the pediatric settings. We do see that it raises some interesting questions around the logistics of that, and so that's something that feels like the next iteration of that conversation at the national level is, you know, now that we can pay for it, how do we share this information, protect this information, store it, all different things like that. but really promising to see states committing to paying for that screening and for referral to treatment. Then in terms of assessment and diagnosis, one really wonderful thing that we've seen is states shifting their policy to allow therapists to have multiple sessions with a young child before they have to submit a diagnosis. So in traditional settings or traditional systems, it has been that maybe you get one session with someone in order to formulate a diagnosis, with the idea being that for an adult patient, you might want one session with them to assess what's going on, formulate your diagnosis, and then chart a treatment course. However, we know that with very young children, it's more complex than that. It takes more time than that. There are a lot of factors to consider, and you're really needing to look at that dyad and get that parental input. And so the recommendation that comes with DC 0 to 5 is that we allow 3 to 5 sessions with a young child. And so we have seen states, New Mexico, Minnesota, North Carolina, and it feels like there are more. I know a number of states are pursuing this right now, and I feel like every time I talk about it, there's somebody else who's gotten it official. So those are just a few of the states who do allow providers to conduct multiple visits before establishing a diagnosis. And I'll say that's one that feels very concrete. I think there are a lot of these that are, maybe a little bit complex, or there are different implications, but that one feels very straightforward to tackle. And we've seen it be one where Medicaid offices have it seems like a good entry point for conversations with state Medicaid agencies, because it's something that is relatively easy to change, and it's easy to understand. When you think about what best practice in infant mental health is, it's easy to understand why our adult setup doesn't work necessarily for young kids, and why we would want to make that change. So I think that's been a really nice starting point for a lot of folks for these discussions. And then just seeing formal ways of integrating DC 0 to 5 into policy. I know you guys already heard about that from my colleagues, and we have a good paper on that on our website as well if you're interested. But in pursuing integration of DC 0 to 5, not just with public insurance, but also private insurance. And then in terms of treatment, we are seeing states try to think innovatively about how to connect really young children with treatment if they don't necessarily rise to the level of needing a diagnosis at this time, but that we know because they are so young, and because their context, their relationships, their environments are so predictive of the considerations that we need to have for them. We're seeing people be really creative about trying to factor in some of these parent-child relational issues and other factors in creating pathways to care. So Oregon allows abuse and neglect to serve as a primary diagnosis, so all children in the child welfare system are eligible for services. Getting that parent-child relational problem diagnosis in as well, and really innovatively talking about other stressors to the primary support group. So Oregon, I think, is a state to watch in terms of the pathways to treatment that they are pursuing. And then Colorado as well has done some great work with their accountable care system, and are now allowing for 6 episodic behavioral health visits without requiring a diagnosis. So those are just a handful of examples that we pulled from that paper, but I encourage you, if you're interested in these, or if you're pursuing something and you're trying to figure out if someone else has done it, if they're in this kind of arena, I would recommend that paper and our DC 0 to 5 policy paper as good starting points. And of course, our team is always available for questions like that.
Well, thank you so much to both of you for sharing this unbelievably impressive and comprehensive information. I know my mind is reeling just a little bit trying to take it all in. I'm going to pause for a moment, see if anyone on who's been listening has some questions. You can feel free to put them into the chat. If there are some questions, we can also unmute the line. So let's just give it a moment and see if anyone has anything to ask.
And perhaps while folks type chat as well.
So perhaps while folks are formulating, okay, we do have one question coming in. I know I had a quick question. I have several questions. Yes, let's go ahead and unmute the line just for a few moments. Please remember, if you're not speaking, to go ahead and put your phone on mute. But let's just give folks the option to either say your question out loud or to type it in. So we do have one question coming in from Rachel, and her question is the hope to have all 50 states participate in cohorts to address? So that's probably a question for you, Lindsay.
That is a great question. Our team is currently trying to figure out what the right sort of path forward is for this project. We have funded or we've pursued funding. It's been supported by the Robert Wood Johnson Foundation, the Irving Harris Foundation, and the Alliance for Early Success. We have pursued funding in cycles thus far, and are really trying to gauge what the interest is in whether new states want to participate, or whether we should pivot and look at deepening within some of the subtopics that we've uncovered. So I don't have a clear answer yet, but just that we are really trying to figure out where there's the biggest opportunity for us to support impact in states.
Thank you for that. Looks like there's a follow-up question. Do you partner with any project launch initiatives directly, launch being funded by SAMHSA?
So when you say, oh, yeah, I was just going to ask for clarification around partnering.
Yeah, I was going to note that we do have, I believe, at least one HealthySteps site that is funded with project launch dollars. It's not really a partnership in terms of the activities and working together, but that is the funding source of, they have a primary care element to it. But yes, happy to understand the question a little bit better.
So Rachel,
yeah,
you can either,
go ahead.
I was going to say, Rachel, your line is unmuted, or you can feel free to type in. We're just trying to make sure we understand what you mean by partnering.
And I can add, while we're clarifying, that we are always excited to see launch at the table. 0 to 3 is not currently, but has in the past provided technical assistance to launch grantees, and we have a real soft spot for an enthusiasm for the work of launch grantees. And so we are always eager to see to make sure that the folks who have worked on launch are able to really get to that state table and kind of share the lessons learned there, because it is such a powerful project. Oh, partnering as a TA provider. Yes, I think that's something we could talk about offline. We, our policy shop does offer sort of like project by project TA, depending on the circumstance, and we provide different types of technical assistance depending on the request. So that's definitely something you can always reach out to us about.
See Rachel's response, because I had sort of a follow-up question to that. Okay, so it looks like Rachel will be able to get in touch with you all. And that was actually Rachel's thinking, I think, along some similar lines that I was wondering about. Lindsay, as you were giving some of those examples at the end, and you mentioned a couple great places to start in terms of printed materials, but I know sometimes it's really nice to just have sort of a phone conversation with someone to really talk about, ways of starting out or, some success stories. So would you suggest that folks start directly by contacting you or someone at 0 to 3, or wasn't sure if there was a contact list for some of those state examples, if anyone was trying to contact more directly? What would be the best way to get support?
Yeah, I think I was just trying to see who we list as the contact on that, on the page where our paper is housed. I'm pretty sure it's me. I would say in terms of, we always want to, we're always very grateful to our state contacts, our state folks, for contributing to publications like this one, but we also want to protect their time. And so I would say for specific inquiries, it would be good to reach out to me or someone on my team. I can refer you. And then, we can make introductions if that is what is needed.
And I just advanced to the slide, but I'm realizing that, Lindsay, your email is missing an L. So my attempt to put our email addresses up for people to contact is actually not going to be very fruitful. So note the L.
So mine is L-Usry at 0to3.org.
Oh goodness, I am sorry we missed that. Okay, that is very good. Yes, please include that L. Other questions from participants? I know that's a lot of information to digest. And if not, you do have all of you now have Lindsay's correct email address, and you have Johanna's as well, and you have the information for Kate and myself. So I'm just going to pivot for a moment and talk about additional ways that you can get connected to those of us on the call and some of the previous information that's been shared on this learning community. So again, as I'm talking about that, feel free to continue putting questions into the chat. But I do want to take a moment to talk about what we at the with this early childhood learning community at the TA Network, in addition to having these monthly times to connect virtually, we are also building and creating a space to connect in between the webinars. So we have a learning management system. It's called Absorb, and it's very easy. We will send information following this call. It's very easy to sign up and to get access. We have lots of information up there now about past webinars. We'll put information about future ones and tons of resources. And in addition, one of the really exciting pieces to it that we are hoping will be of great benefit to you all is a place where you can ask questions and get feedback from us and from your peers, hopefully in close to real time. So all that is available on our learning management system, and Tiara just put the link in the chat. So it's institute.myabsorb.com. You see that there. As I said, we will send out some additional information through email as we are growing those that are connected through Absorb. But we're really excited about it because we understand that sometimes you sit on these webinars and you hear this, phenomenal information, but it's a little bit overwhelming, and sometimes it's hard to think about what to do first, and then you kind of get back into the daily grind of your job. So we are hoping that this is a platform where you can continue to reach out and gain support and revisit all the the resources, not just for this webinar, but from others in the past. Okay, I'm going to ask one more time if there are any lingering questions. And if not, please do look out for that email. We will give you information about how to log in. And we're going to close in a moment, and Tiara is going to put up the link to complete the evaluation. And we really do hope that you will take just a moment to complete this evaluation. It helps us make important changes moving forward to ensure that we are having this be a time that meets your needs, because that is what it is for. All right, and if there are no further questions, we are happy to give you 13 minutes back in your day so you can have an actual transition to your next meeting. Thank you very much, Tina. And Lindsay and Johanna, thank you so much for providing this great information and expertise.
Thanks for having us.
Thank you for having us.
Thank you. Have a wonderful day, everyone.
Take care, guys.